Assalamu alaikum. This presentation is on the identification and quantification of aspiration by the use of video-fluoroscopy, the gold standard, and a special validated scoring system, the Penetration-Aspiration Scale PAS, which is also now the gold standard for the quantification of aspiration. We'll go through the scoring, how to interpret, and the limitation of the scoring system. Videofluoroscopy remains the best available method of identification and quantification of disorders of the swallowing, pharyngeal dysphagia, and/or aspiration. The amount of information provided by videofluoroscopy is enormous and covers the flow of the radio-opaque bolus. It's the timing, the patterns of failure or disorders during the swallowing act, any regurgitation up the nose or any spillover in the larynx. Because such amount of information is vast, it's usual that the video is run several times, some of them with a slow motion. It's also essential that we focus on one aspect of the swallowing act at a time and use validated scoring system to register any abnormalities in that act. When we are looking at any evidence of aspiration, we use the penetration aspiration scale, which is the gold standard of quantification of aspiration. If we are looking for problems in the flow of the bolus down the hypopharynx into the esophagus, we use things like the pharyngeal residue scoring system. In this presentation, we'll focus on the penetration aspiration scale, which scores the various degrees of aspiration. The penetration aspiration scale was proposed by Rosenbek and his colleagues in 1996 and remains the gold standard method of quantification of aspiration using the videofluoroscopy. It's an 8-point scaling system to quantify the severity of aspiration according to the depth of invasion of the aspirate material in the airway, whether it is in the supraglottis, the glottic levels, subglottic, or the trachea, and whether the aspirate material is ejected promptly from the airway or it remains there. The method should be fairly reliable and stable, and there are ways to improve the reliability and the stability of the scoring system, including group rating rather than individual rating of the degree of invasion and the severity of aspiration, and reviewing the videos in slow motion as well as real-time speed, and judging the degree of the invasion by the validated scales. We know that stability, like the agreement between the grading of the swallowing and different textures and volumes of the bolus, can vary between subjects and can vary within the same person itself according to things like the bolus volume, the bolus consistency, the concentration of the barium. And by following up the radio-opaque bolus by group rating, things like inferences regarding the sensory or the motor integrity of different parts of the larynx can be reached. The penetration aspiration scale is an 8-point scoring system reflecting the severity of aspiration by the depth of the invasion of the aspirate material down the airway, starting with 1, in which there is no aspiration, the material does not enter the airway, the examination is normal, and the most severe form of it, number 8, in which there is silent aspiration, the aspirate material goes all the way below the vocal folds into the trachea or even the bronchi, is not ejected, and there is no attempt at cough because there is failure of the sensory as well as the motor mechanisms to clear up the airway from aspiration. Between 1 and 8, it goes into different levels according to the depth of the invasion. In 2 and 3, the aspirate material remains in the supraglottis above the level of the vocal cords. In number 2, the material is ejected after it penetrates into the supraglottis. In number 3, it does not eject because there is a failure of the sensory element of the supraglottis, the superior laryngeal nerve. In 4 and 5, the aspirate material goes a bit deeper and contacts the vocal folds into the areas of directly above the vocal fold. Again, number 4, it's ejected from the airway during promptly, and in number 5, it is not. In 6 and in 7, the material goes below the vocal folds. In number 6, again, it's ejected from the airway by a good cough reflex. In number 7, it's the ejection is attempted, but the material is not completely cleared. So we know that there is a sensation in the subglottic and the tracheal area, some sensation, but the cough is not effective in clearing up the airway. In number 8, the material goes all the way down below the vocal folds into the trachea. It's not ejected, and there is no effort made to eject it because there is sensory as well as motor failure. Now that's the important issue. That's what matters at the end. How the scoring itself is done. How can a video clip with a certain swallowing pattern or aspiration be summarized into a grade like a pass 6 or 7 or whatever? And it's important to note that the scoring can differ between different raters for the same video clip. It's also important to know that the scores may vary within the same person across a series of swallows if it's repeated. And of course, the scoring can vary across the same patient again with different bolus volumes or consistencies between, say, for example, fluid or semi-fluid or solid, and different postural maneuvers adopted by the patient himself. We usually take the worst score as indicative of the degree of severity of aspiration, but there are some doubt about the validity of this, and some would argue that taking an average would be a better reflection of the degree of severity. The scoring should be done in a systematic way to allow comparison within the same patient and between different patients. And the test bolus should be started by a small volume, and then the volume is increased in subsequent swallows to minimize the risk of aspiration of large amounts if there is a failure at any level. And a range of different food textures, consistence between fluids, semi-solids, and solids are usually adopted. And now we'll go through the 8 different levels of the penetration aspiration score, starting from number 1. Pass number 1. The bolus is swallowed normally. All of it will go into the hypopharynx, and there is no penetration into the airway. So that's normal. That's number 1. The next level is penetration aspiration score of 2, which is sometimes called flash penetration. You would see a very brief attempt at penetration of the bolus into the laryngeal vestibule that is promptly cleared off the larynx down the hypopharynx. This is a very brief attempt at penetration that's promptly cleared completely out of the airway and swallowed. And this can be passed as normal. It's not seen as an abnormality because it happens so often in normal subjects. This is followed by pass 3, in which there is a penetration to the supraglottic space, but it does not clear up promptly. It does not trigger an immediate swallow response. You would see that the bolus here had lingered around in the supraglottis,
just below the epiglottis and above the arytenoids, and is not cleared. And that would make us think that the superior laryngeal nerve integrity or the sensory integrity of the supraglottis is affected. So there isn't a prompt response to clear this bolus from the supraglottic space. That's pass number 3. Pass number 4 is rare, in which the aspirate material dips deeper in the supraglottic space and actually touches the vocal folds. And then it excites the swallowing reflex and it is promptly cleared completely. So you see that there is a little bit of aspiration here that dips into the supraglottic space above the vocal cord, but it's now completely cleared of the airway. Pass number 5 is similar to pass number 4 in that the material enters the airway, dips deeper in the supraglottic space, touches the vocal fold, but this time it is not ejected from the airway. You'd see the bolus penetrating into the larynx, pulling deeper into the supraglottic space, and now touching the vocal folds. This is the arytenoid there, and it's not ejected. And then we can question the integrity of the reflexive, sensory, or motor responses of both the superior laryngeal nerve and the recurrent laryngeal nerve. In number 6 level, the aspirate material dips even deeper into the airway, passes the vocal fold levels into the subglottic space and the trachea, but then it is promptly cleared by the cough reflex and the coughing of the material from the trachea and the subglottic space back into the supraglottis. You would see how the aspirate material dips deeper now into the subglottic space, but it's promptly cleared by the coughing into the supraglottic space and ultimately swallowed by the patient. This is actually a very rare level. It's seen in about 3% only of the video clips. Number 7 level is similar to number 6 in that the aspirate material passes the vocal fold level into the trachea. It's also similar to number 6 in that there is an attempt at coughing up of the material back into the larynx, but different to number 6, the cough response is not effective, and therefore a residual amount of the material remains into the trachea despite the effort at clearing it. You would see some aspiration here into the subglottic space and the trachea. You would see attempts at coughing, but there is a residual amount of the material in the trachea at the end because the cough reflex was not very effective. So we know that there is still some residual sensation in the recurrent laryngeal nerve sensation territory, but it's not effective enough to clear the airway from the aspiration. And finally, to the last level, where there is silent aspiration in level 8. The aspirate material passes through the larynx, the vocal fold levels, into the trachea. It's not sensed in the trachea, and there is no attempt at coughing it, and it passes directly into the airway. You see the aspirate material going directly through the trachea into the airway with no attempts at coughing. Then we know that there is an impairment of both the sensory and the motor arcs of the cough reflex. It's important to note that the 8-point penetration aspiration scale was originally meant to reflect increasing degree of severity of aspiration between the different levels, so that level 8 is severer than level 7 and level 7 is severer than 6 and so on. It's not an interval scale in which the distance between any two adjacent levels are equal. Nothing like this could be claimed in the penetration aspiration scale. The distance and the degree of the severity of aspiration between, say, level 8 and 7 is not equal to the degree of severity difference between level 4 and 3. So at best, it's an ordinal scale in which every level is severer than the preceding one and less severe than the following one. Although this is also debatable with some levels, as we will explain later. So it's at best an ordinal scale, not an interval scale. The importance of it is that if we are doing any statistical manipulation for data from the Videofluoroscopy penetration aspiration scale, you should be using non-parametric tests and not parametric tests because it's at best an ordinal, not an interval scale. Why the penetration aspiration scale is considered at best to be an ordinal scale is because there is a considerable amount of doubt about the way the scale, the degree of severity in the scale reflects degrees of severity of aspiration. McCulloch et al., for example, 2 years after the original description of the scale, has questioned this, and through a questionnaire to the consultants in the UK, he found that 87% of the consultants thought that level 3 is actually more severe than level 4, because in level 4 there is effective ejection of the penetrated material, although the material was aspirated deeper into the supraglottic space. Something similar, 71% thought that level 5 is severer than level 6, again because in level 6 the aspirate material is cleared by coughing, whereas in level 5 it's not ejected. And take it further, 58% thought that level 3 is actually severer than level 6, because in level 6 again the aspirate material is cleared by cough, whereas in level 3 it's not ejected. So at best the penetration aspiration score is ordinal, and some would actually consider it categorical rather than ordinal. The penetration aspiration scale was originally proposed to grade the severity of aspiration depending on the depth of the invasion into the supraglottic or the glottic or subglottic spaces, and therefore quantify the risk of developing pneumonia or other adverse conditions through the aspiration. But it's important to note that the risk of developing pneumonia or other chest conditions through aspiration is also dependent on other factors, not only the depth of the invasion, including the volume of the aspirate material itself and whether the aspirate material is expelled promptly or is retained after any attempts at coughing, whether it is contaminated either by bacteria or other chemicals, and whether the general health of the patient and his immune response is affected by other factors like advanced age, oral health, dependency on and certain medications, and of course the type of the feeding and the ambulatory versus bed-bound status and the use of tube feeding. So there are other factors that affect the risk of developing pneumonia other than the penetration aspiration scale, which only reflects the depth of invasion of the aspiration. The penetration aspiration scale can also be used to grade the severity of aspiration through the video endoscopy, not only through video fluoroscopy. And there is a very good amount of agreement between both techniques of measuring aspiration. If you use things like video endoscopy to grade the aspiration, we're using the same scale, registering any aspiration of the material into the supraglottis or the glottis of the subglottis with the same scale, you get an 82% degree of agreement between the video endoscopy and the video fluoroscopy. The penetration aspiration scale remains the gold standard in the identification and quantification of aspiration, not only through video-fluoroscopy but also with video endoscopy. But it has its own limitations, and it's important to allow for this. It does not, for example, estimate the volume of the aspirant material, which is an important risk factor in the development of pneumonia. It does not capture the timing of the airway invasion, whether it is before the swallowing reflex or during it or after the swallow. It does not provide an ultimate diagnosis about how things had gone wrong and which part of the mobile aerodigestive tract had failed. It does not tell you whether there is premature escape of the material from the pharynx and the mouth into the larynx, or whether there is a delayed laryngeal vestibule closure or elevation, or whether there is a spillover of a residual bolus that had remained in the pharynx and spilled over in the larynx later. Despite limitations, the video fluoroscopy estimation by the penetration aspiration scale remains the gold standard. And there are other limitations for the use of the video-fluoroscopy in general and the penetration aspiration scale in particular. There is, of course, the risk of radiation exposure. 3 minutes exposure to the video-fluoroscopy is equivalent to a radiation exposure of 2 cervical spine radiographs. There is the cost involved in the equipment and in the personnel. There is also the difficulty in positioning the patient for the test, particularly if the patient is bedridden, for example, or after generalized neurological problems. There are issues with the grading for the penetration aspiration scale with different bolus volumes and bolus consistencies and concentration of the barium inside. And there is also a limited amount of information gained about the type of abnormalities in the aerodigestive tract mucosa, for example, any secretions in there, the sensation in there, the interbolus pressure, and the glottic closure. And finally, although the penetration aspiration scale remains very useful, there are continuous attempts at improving things. And one of these attempts suggested that it can be reduced into a 6-point rather than 8 points. The number 1 and number 2 remains the same, like in the original penetration aspiration scale. Number 5 and number 6 also remains the same. The changes would happen in 3 and 4. 3 would actually be the original 3 and also 5 pass scale, in which the material enters the airway, contacts the glottis, stimulates cough, and is not completely ejected, while in number 4 it passes below the glottis, stimulates the cough reflex, and is ejected completely, like the original number 6 level. So there are attempts at improving and simplifying the scale. In this presentation, we focused on aspiration, the penetration aspiration scale, and the events in the video fluoroscopy that shows a depth of the invasion of the airway. In the next presentation, we'll be focusing on the pharyngeal features of video fluoroscopy during examination of pharyngeal dysphagia. Salaam alaikum.